Hello, everyone. I'm Karol Quelal, one of the first-year cardiology fellows at the Mayo Clinic. I'm having the pleasure to be here with Dr. Gregg Stone. Thank you, Dr. Stone, for agreeing to interview with us. This is a project for all the fellows to be having access to the late grounding clinical trials that are published in the ACC, now in the ACC 2024. Dr. Stone, can we discuss something about the Relief HF trial?
Of course. So yesterday, the American College of Cardiology, we presented the principal results from Relieve HF, which people were looking forward to for a long time. And the concept was that in patients with heart failure, their major symptoms are shortness of breath, dyspnea on exertion, and often the left atrial pressure is elevated, which leads to pulmonary venous congestion, and it's often elevated for days before pulmonary edema develops that causes heart failure hospitalizations. So we've thought for many years that if you could create a small communication, small hole between the left atrium and the right atrium, that it could serve as an autoregulatory mechanism that's on 24/7, 365, that whenever the left atrial pressure rises, it would increase the amount of blood that would shunt from the left side of the heart to the right side of the heart and decrease the left atrial pressure to make the patient less breathless and less likely to be admitted for heart failure. And so there are about 10 different companies that are developing different shunts or mechanisms to create these small communications. And this was the second pivotal trial in this space. And what we did in Relieve HF is that we randomized 508 patients with heart failure of any ejection fraction. And you know, there's almost two separate diseases. There's reduced ejection fraction, where the heart's weak from either prior heart attacks or cardiomyopathy, and the heart gets dilated. And then there's heart failure with preserved ejection fraction, which can either be recovering reduced ejection fraction, or it could be LVH or diabetics with cardiomyopathy, where the heart gets very stiff. It's not enlarged, but it gets stiff. But either way, the left atrial pressure goes up. And so we randomized 508 patients in a placebo procedure or sham-controlled trial to receive a specific type of shunt called the V-Wave Ventura interatrial shunt, which is it's an hourglass-shaped device. It's very small. It's got about a 5-millimeter orifice, and it affords about a 1 liter per minute blood flow from the left side of the heart to the right side of the heart. And again, patients either got the shunt or they got the sham control procedure, where they didn't know whether they were getting the shunt or not. And then we followed patients for 2 years up until the last patient reached 1 year follow-up. And we looked at safety, which was among shunt-treated patients. Were there any device-related or procedure-related major adverse cardiovascular and neurologic events? And we actually saw no such events. So it was a very, very safe procedure. And this is a relatively easy procedure for an interventional cardiologist to do in the cath lab. It only takes about 30 to 45 minutes. We had an effectiveness outcome, which was a hierarchical outcome of 4 cardiovascular events followed by an improvement in quality of life. And so it was all-cause death, LVAD or heart transplantation, heart failure hospitalizations, or outpatient worsening heart failure events. And again, if those events didn't occur, then we'd look for change in quality of life measured by the KCCQ score. And in the overall trial, there was no difference in effectiveness between the two groups. However, we weren't certain whether the results were going to be similar in patients with reduced and preserved ejection fraction, and so we performed 2 stratified separate randomizations in those groups. And what we found was the patients with reduced ejection fraction had marked benefits in terms of cardiovascular events. They were a very high-risk patient population. They had about a 45% reduction in adverse events, driven by a 50% reduction in heart failure hospitalizations, with trends towards reductions in all-cause death, LVAD, heart transplant, and all other events. In contrast, the patients with preserved ejection fraction had almost a doubling, actually a 68% increase in adverse cardiac events, driven by a doubling of heart failure hospitalizations and actually a 3-fold increase in mortality. So all-cause death was increased in patients with preserved ejection fraction who received a shunt. When we looked at the Kansas City Cardiomyopathy Questionnaire, interestingly, that improved in all patients. And it wasn't different in the 2 different groups, regardless of whether they had reduced or preserved ejection fraction. So there was a big placebo effect. Everybody kind of felt that they went through this procedure, they all felt that they were getting better, and it really didn't correlate with how they were doing in any regard. So this is an investigational device in the United States. It actually has CE mark in Europe, but it's going to clearly, it implies that patients with heart failure and reduced ejection fraction might benefit in an important way from shunt treatment such as this, wherein patients with heart failure and preserved ejection fraction, at least the sick patients that we enrolled in this trial, could really be harmed by shunt therapy. So despite the fact that the left atrial pressure is this final common denominator in both of them, the structure of the heart is so different that the stiff heart with HFpEF can't tolerate that increased blood flow from left to right, where the more compliant heart in HFrEF, heart failure with reduced ejection fraction, can tolerate the increase in blood flow. So it provides a lot of important new data for future investigative directions as well.
That is very, very interesting. So for patients with heart failure with reduced ejection fraction, what would be the population that you think would be a better candidate for them out of the reduced ejection fraction patients?
Well, so right now it really looks like the patients that we studied in this trial. So it's the ejection fraction less than or equal to 40%, patients who remain symptomatic despite being on all maximally tolerated doses of guideline-directed medical therapies, CRT if appropriate, and patients who had either been hospitalized for heart failure or have a elevated natriuretic peptide level and had a diminished 6-minute walk time, so evidence that they're really functionally limited. Those patients really benefited, and it'd be nice if this device was available in the United States for use in such patients.
What do you see for the future? Do you think that the device is going to be approved in the near future?
Well, again, I don't speak for the FDA, so there'll certainly be regulatory discussions towards that end, and there'll be a lot more studies to come in patients with, at a minimum, heart failure with reduced ejection fraction. Then the question is for heart failure with preserved ejection fraction. There are other studies ongoing with different shunts in those patients, but they're much lower risk patients than the types of patients that we enrolled in this trial. So maybe there's a carve out of some very low risk patients with preserved ejection fraction where these types of shunts can be safe, but we'll have to see.
We'll have to see. Thank you so much, Dr. Stone. For more videos like this, please follow us in social media, YouTube and X at FITsOnTheGo. Thank you.